welcome, Arif. Arif, I also met at one of the Nuffield Trust conferences, which was fantastic. And interestingly enough, I came across the idea of Blackpool being unique globally in one sense before I met Arif, but he confirmed my prejudices and understandings and has retained my interest in what I consider to be a very fascinating part of England. Arif is the Director of Public Health, Blackpool Council, but I'll pass you on to Arif to provide a bit of background and then your presentation. Thank you, Arif.
Thanks, Nadeem, and hello, good afternoon, everyone from sunny Blackpool. It's always sunny in Blackpool. We get 20 million visitors every year, nation's favourite tourist destination. So please, if you haven't been to our great town, please come and visit us. I'm sure many of you will have your own memories of Blackpool, but behind all the glitz and glamour, we do have our health challenges, and I'll talk about some of those things. And then you've got Maggie, our acute trust chief exec, next, so you've got a very heavy Blackpool focus. Can I have the next slide? I've only actually got one slide which I want to take you through really and present to you, which I think will hopefully help us think about a framework of how we tackle health inequalities. And I hope you can see this slide, which is sort of split into the short term, medium term, long term. Ultimately, what we're trying to do is improve life expectancy, improve healthy life expectancy, and reduce health inequalities. And this slide I've stolen from Professor Chris Bentley. He's done a lot of work on health inequalities, and I think he captures the sort of framework of how you should think about tackling inequalities in a very succinct, clear way. So if I take each one of these, and then we can maybe talk about things, and you can throw some questions into the mix in the chat. So long term, these are the sort of social determinants of health, such as worklessness, poor housing, poverty, poor educational attainment, giving kids the best start in life. And those are the sort of longer term. So we have to do those things now to get our payback in years to come. So there's a 15, 20 year plus sort of payback time scale. And it's important to recognise, now, if we're talking about the NHS specifically, now, I work in a local government setting, and we've got economic regen happening here. We're obviously trying to work on creating good quality jobs, tackling poverty, tackling childhood poverty. The NHS still has a role here, and Maggie will talk about some of this in due course around the NHS's role around the sort of wider determinants of ill health, the Anchor Institute stuff, making sure we're providing local jobs, we're commissioning local businesses to do some of our stuff. Equally, I think when you're talking about giving kids the best start in life, if you're talking about the 0 to 3 sort of intervention, speech and language therapy has a very crucial role in getting our kids school ready so that they can get that educational attainment and bring them out of social exclusion and poverty down the line. So the NHS does have a role in that sort of long-term time frame. You've then got the medium term. Now, for want of a better term, I don't like the term lifestyle issues, but alcohol, drugs, tobacco, obesity, all of those things. Now, of course, me and my team commission quite a lot of services around that, but the NHS has a role in tackling some of those issues around what you might call lifestyle issues around alcohol, for instance, alcohol care teams in acute trusts. We've got smoking cessation in inpatient settings, etc. So there's quite a lot of work happening there. This is an area where we do need government action as well. So it's not just about local action. This is about government action. So, the obesogenic environment driven by junk food advertising, looking at a salt, sugar, reformulation tax, minimum unit price for alcohol. Those are government level interventions which will really help us drive some of the improvements, public health improvements in those lifestyle issues. So I think the government also needs to invest some political capital rather than just financial capital in those interventions, in those sort of medium term interventions. And then we come to the short-term interventions. So these are the purview of the NHS, many of these things. So things like identify and treat models, around blood pressure, cholesterol, smoking in pregnancy, which has an immediate impact if we can tackle that. Also, immunizations and screening, all of those things that are sort of bread and butter NHS type interventions in that. So that can have a short-term impact. Now, having said all of this, I think the key thing for me is how do you actually reach your communities? And that's why it's fantastic listening to Samira around, engaging with your communities. We really need to get into communities and tackle those issues. So just to give you a live example around the sort of NHS interventions around immunizations, we've had an issue around measles, and we've been increasing MMR vaccinations currently. One of the things that me and my team have commissioned locally has been to sort of do a home visiting service around MMR vaccinations. And the one thing the public and the patients said to us, was that, it's sometimes not convenient to try and get to the GP practice between 2 and 3 on a Tuesday because I'm trying to hold down 2 jobs. I've got other responsibilities, I've got caring responsibilities. Could you not offer this at the weekend? And that's exactly what we did. So we've offered those vaccinations on a Saturday, Sunday, and that's improved our vaccination rate. So it's really important to understand, your communities and understand that. Now, the key thing for me, which I think people sometimes don't grasp, is if you're going to tackle health inequalities, you need to invest your time and money in that. It takes more resources to tackle those inequalities. There is an investment that needs to be made, but of course that investment then comes with benefits down the line because you're preventing some of those illnesses and diseases. So these are some of the key things that I think as a system we need to tackle. And I think the point's been made is that when you're talking about tackling health inequalities, I think the NHS has a role, local government has a role, and national government has a role. I think you have to do things at place level. That's the other key thing for me, is that if you at place level, we understand our communities. And this is some of the challenge that's currently in the system around the ICB system, is that it sometimes feels very remote, the organizational structure that currently exists. And what we need to do is have more place-based approaches. We did have place-based approaches in previous organizational structures when we had Blackpool CCG and prior to that Blackpool BCT. But now I have this thing called Lancashire and South Cumbria ICB, which sits far more remote to me at the local level. Places where the action is, places where we understand communities, places where we can design those interventions that meet the needs of our communities. And just in the way that's been described, you need to engage with your communities around that. One of the things that struck me is that the rhetoric does exist around prevention now. People are talking about prevention more. The NHS is talking about prevention, but it still seems the ICB still seem very focused on saving money rather than investing in prevention. That shift has to happen. That person-centered care, and Maggie will talk about the trust in a moment, but when a person goes into the trust, let's provide them with person-centered care as opposed to just treating the disease. We need to look at the person holistically and get the right intervention to them. I could go on, but I'll stop there and take any questions from the floor. Thank you, Nadeem.
Thank you, Arif. No, fantastic. I mean, we are running behind time, but I still wanted to. So many questions have come through on a number of the presentations. You focus on the idea of place being the starting point where we should really make the difference. We are, of course, working with Maggie and her team on the idea of what place fundamentally means and how one makes that real rather than just a concept. Can I just challenge you a little bit on your role as Director of Public Health then, right? So
yep.
There's a lot of conversation about prevention, and briefly, my challenge is really, if we were serious about prevention, then it is about those things that are your economic strength, your educational foundation, your environment, your house and your environment, your culture and your communities, that if those aren't addressed, that surely is the best source of primary prevention, rather than what we are talking about, which is, I consider health inequalities to be the outcome of inequalities, and therefore we're dealing with symptoms. So when you're dealing with blood pressure, when you're dealing with ulcers, when you're dealing with dental caries, when you're dealing with smoking, and you're dealing with obesity, I consider them to be the symptoms of the inequality burdens that these folk carry, and therefore we're just symptom managing rather than dealing with the core drivers. All I'm asking is, does that make sense? And is that a bigger challenge for the system to think about rather than the NHS?
Yeah, absolutely. And this is why I think I made the point that there are short, medium, long-term horizons for all of these interventions. And really, we should be addressing the causes of the causes, which is the point that you're making there. So absolutely, we need to do that. But equally, the way I look at it is that if you look at worklessness and ill health, it's a circular argument. Work is good for health. You know, being in work is good for health, um, uh, and keeping people in work is important to maintain that good health. Equally, people will with ill health often struggle to get into work. So where you intervene in that circular argument, doesn't really matter to me, because we need to intervene. Because if the person's got ill health that's stopping them from getting into work, we need to get them to a position where they can do a job. They might not be doing the same job they did previously, but they could do another job and get. So we need to improve their health, working with employment advisors. This is one of the things that we're working on with Work Well program, which is exactly about doing that. So try and give people good jobs, keep people in work. If they become unwell, let's make sure we intervene very quickly so that they're not on long term, because we know if we intervene in the first 3 months, we've got a good chance of getting them back into work. So that's the key thing. Is I think everyone's got a role in this to contribute to the goal of improving health and reducing health inequalities.
Right, thank you for that.